first?
Yeah, of course. Hi, I'm Alicia. It's great to meet you, Dr. Melchior, even virtually. I'm from Columbus, Ohio, and I am currently a second year at Feinberg right now. And I guess something fun I did over break was just spent a lot of time with family, watched the Ohio State Michigan game, which unfortunately did not go the way that we would have wanted, but it was still a good time.
Yeah, I saw part of that game.
Unfortunate.
I'm sorry.
And I'm just going to go down by this. Jared, you're next on my screen. So if you don't mind introducing yourself.
Sure. Hey, Dr. Melchior. I am Jared. I'm a first-year medical student. I'm originally from York, Pennsylvania. And something fun I did over break was I got to go fishing like 4 or 5 days in a row, which I haven't gotten to do in downtown Chicago. So it was a nice change.
Ice fishing or regular fishing?
Regular, like on a stream.
Are you a fly fisherman or lures or bait?
Yeah, fly.
Classy, very classy.
Yeah.
My husband's a fly fisherman. I'm terrible at it, but he loves it.
It seems like everybody from Colorado is, so.
And then Hunter, you're next on my screen.
Hey, how's it going? So Hunter Angelari, also an M1 from the Metro Detroit area over in Michigan. And I guess not so fun thing I got to do is watch the Lions play on Thanksgiving. I'm a Detroit Lions fan, unfortunately, but it's the one time of the year I get to see them play on prime time.
We're gonna win.
Still chasing that first win of the season.
And then Oscar, you're next on my screen.
Hello, I'm Oscar. I'm an M2. And over the break, I was back home in Bethesda, Maryland.
Cool. And then Lexi, I think you're on just without video. Oh, she said background is very noisy. She's from Northbrook, Illinois, and an N1. Let's see. And she, over break, she did a lot of eating. So that's great. All right, I think that's good. Alicia, if you don't mind taking it away with some of your questions.
Yeah, sure. I can start with some of the ones that were submitted over email. So I think maybe just a good one to start with was, Dr. Melchior, how did you get interested in orthopedic surgery, and like what was your path like to pursuing the field?
So when I started med school, I was pretty sure I wanted to be a surgeon, but I was not thinking about ortho at all. And I had a bunch of buddies my first year, and a lot of people were going into ortho, and I just thought, yeah, whatever, not sure why you're interested in that. I thought I wanted to be a cardiac surgeon or a plastic surgeon. And at the time, third year med school, we had, during our surgery rotation, it was 12 weeks, and there were set rotations that you did. And you did 4 weeks on general surgery, 2 weeks on ortho, 2 weeks on cardiac, and then the 2 weeks on anesthesia. And then I forget, there was one other 2-week thing. And I didn't want to do the 2 weeks on ortho because I thought, I don't want to go into ortho. And so I went to the clerkship director and said, could I do 2 weeks on plastics instead? And they said, no, you just go do your 2 weeks on ortho and stop complaining. And I was like, oh, okay, fine. So much to my surprise, I had the best time on my 2 weeks of orthopedics. And the way they did it at the time was I was paired up with an attending, and I basically shadowed him straight for 2 weeks. I went to the office with him. I went to the OR with him. I went to the ER with him. I basically just followed him for 2 weeks straight. And he was a total joint guy up at Evanston Hospital. And I had so much fun. And I realized, wow, these surgeries are great. And going to the emergency room, the residents were they loved what they were doing. And that was one of the first rotations where I'd really met people who were really happy to be there, and they really loved what they were doing, and they loved ortho, and they wanted me to love it too. And so they taught me a lot. So as a third year med student, I learned how to aspirate a knee, and I learned how to reduce a distal radius fracture. And, in the operating room, they taught me so much. And had a terrific rotation. And so after that, I thought, wow, I might actually be interested in going into this. So my 4th year, I did some sub-Is in ortho, one at Northwestern and then one at UC San Diego. Plus, I did spend some more time on cardiac and some more time on plastics. And I came to the conclusion that I didn't really want to be a cardiac surgeon and I didn't really want to be a plastic surgeon. And that's how I ended up in ortho.
Thanks, that's awesome. I feel like my follow-up question to that would be, I think a lot of people are interested in plastics and ortho because they can be similar fields. And so what stood out to you about ortho over plastics and made you like make that final decision?
So at the time, it's different for you guys now. At the time, most plastic surgery programs, you had to do a full 5 years of general surgery and get boarded and then do 2 or 3 years of a plastics fellowship. So it was a 7 or even 8 year process, depending on the programs you were at. And I really just wasn't interested in doing 5 years of general surgery. And so now you can do combined programs where you only have to do 2 or 3 years of general surgery and then usually 2 years of plastics. So it's much more condensed now. And so you get to plastic surgery much more directly than we used to. And I think that's part of why I ended up as a hand surgeon, because I really like the plastics aspect of it. And so it's for me, again, deciding to go into ortho, I had no idea I was going to be a hand surgeon. I thought I was going to go into sports, which is what a lot of people think when they go into ortho. Most people going into orthopedics think, oh yeah, I want to work with teams and or I was an athlete. And so that really appeals to me. And sports is great. But I realized over the course of orthopedic rotations that I liked the breadth of hand surgery because we take care of patients from really small babies all the way to people to 100. And we see so many different things and there's a ton of variety in hand. And I like that. In sports or in total joints, they tend to do a lot of the same procedures. So, if you go into ortho and you decide you're going to be a total joint surgeon, you're going to do 4 procedures. You're going to do total hips, total knees, revision total hips, and revision total knees. And if you go into sports, your top 4 or 5 are ACLs, rotator cuffs, labral repairs, and meniscal repairs. So there's about 4 procedures that my sports and joint partners do a ton of. Whereas in hand, I've probably got 20 procedures I do a lot of. And I like the variety, but it really appealed to my inner plastic surgeon, if you will, because I really liked the delicacy of it. I like the fine anatomy, and there's a lot of stuff in a small space in a hand. And that's not necessarily for everybody, but it's something that really appealed to me. And so my hand fellowship was a combined orthopedics and plastics hand fellowship. So I got to spend a lot of time with the plastics guys as well as with the orthopedics people, which was great because I did a lot of free flaps as a hand fellow. And I also did a lot of, ORIFs, and we did replants, and, I got to see it all. And so, for me, this was a really good fit being in hand surgery. It kind of blended what I liked about plastics and what I liked about ortho.
Thank you. That was super helpful and very thorough. Another question that was asked a few times by people was people are interested in becoming surgeons, but wondering about the work-life balance, especially being a parent and being, I guess, also just a woman in surgery. Can you speak a little bit about your experience and how you found a balance between those things?
It definitely takes time to figure out what balance works for you. And this is true for any gender. It's at first, when you're in residency, some of us were single, some people were married, some people had kids. And then, things evolved over the course of residency. And, I had friends who got married during residency. I had friends who had kids during residency. And it's hard to do those things during residency. I will tell you that. I was not married and I didn't get married until 4 years after I finished my fellowship. And for me, that worked out really well because I was being single during residency for me was really good because you're working really hard and you're working really long hours. And it's challenging to balance everything you're trying to do at work with then a home life. And it's, if you're married and or having kids during residency, I think it helps tremendously to have a really committed spouse. And you can't do it alone. It's, you know, definitely it's a group effort, that's for sure. And so I think it's something that evolves over time. I'm sorry, that's my landline. Let me just stop that. It's definitely something that evolves. You have to figure out what works for you. And for me, what gradually evolved, and I've been in practice for almost 25 years. And for me, what gradually evolved is that I eventually went from working full-time to, I cut down a little bit when I had my first daughter, who's now 17. I cut down a little bit. I worked about 90% instead of 100%. And then when we moved to Colorado, I was in Los Angeles in practice for 8 years and then moved to Colorado. And we've been here for 16 plus years. And so when I came to Colorado, I went back to working full-time, you know, new practice. And then several years ago, I went down to working 3/4 time after I had my second child, my second daughter. And for a while, both my husband and I were working full-time. And it was really challenging. It was really challenging. We were, life depended heavily on our nanny. And you definitely will need family or a fantastic nanny like we have to make all the moving pieces fit together like the way they're supposed to. But it's definitely, there's going to be some trial and some error to it. You know, for some people, working part-time is what ends up working out. For some people, you might be working full-time and your spouse might not. They might work part-time, or they might decide that it's better for your family that they're at home with the kids. And it is definitely a balancing act, and you won't always make every kid's concert or play or sporting event that you want to. And you really want to try, of course, as a parent, you want to be at everything. But it's also important that you have your own life too. And you do need time to see your friends. And it's really important to remember you too, which is hard. And so it's a real juggling act. It's doable. It is absolutely doable. I don't want anyone to be discouraged about going into any surgical specialty because you think that if you go into this, you can't have a family, or you can't have outside interests. It's actually really important to have outside interests. I play volleyball twice a week, and I run, and I have friends that I get together with, and it's really important to have those outside interests to balance everything that you pour into work. Looks like somebody new joined us. Hi, Alex.
Hi, I'm so sorry. My last meeting ran late.
No worries. I'm Julie Melchior. I'm an orthopedic hand surgeon in Boulder, and I was just talking a little bit about work-life balance, being a surgeon and a mom and a spouse, and also trying to have some of your own life too.
Alex, do you mind just sharing what year you are in school, and what's something you did over Thanksgiving break?
Okay. So yeah, hi, I'm Alex. I'm an M2. Again, so sorry I'm late. And over Thanksgiving, I went to the Michigan-Ohio State game.
We have some Michigan-Ohio State fans here.
But were you happy with the outcome, Alex?
Absolutely.
Alicia wasn't. We were just talking about that.
I know, very disappointing, but they had to get one win in there in the last few years. But anyways, thank you so much for answering that question. Another one that was asked a few times was, do you wish you had either known or done anything differently in medical school? I know you talked a little bit about your journey and how you really like found that like interest and excitement like your third year during your rotations. But is there anything that like if you were in our shoes, you'd recommend us to do? Yeah.
Well, I think the first decision that you make in med school is, do you want to be a surgical track or do you want to be a non-surgical track? And that, I think if you make that decision early, it makes the rest of the decisions more smooth. Sometimes it's hard to make that decision. And I had friends who liked aspects of surgical specialties and they also liked aspects of primary care. And oftentimes those kind of middle of the road folks ended up in either ER or OBGYN because there's aspects of both. And for me, I was always going to be a surgeon. It's just how my brain worked. I didn't have a surgeon in the family, didn't really even have a physician directly in the family. I had a couple of aunts who were nurses, but that was about it. But it's just so much of it is it's just the way you think. And for surgeons, we want to know what's the problem, what do we need to do to fix this, what are our options, and let's move forward. Whereas my friends who are in primary care, they really thrive on, they want to know kind of everything about their patients and they want to know them for a long time and they want to, kind of be with them and the family and oftentimes take care of multiple people in the family. And so they like the longitudinal aspect of things very much. And it's funny in orthopedics, you'll find that there's a lot of times where you do have that longitudinal component. I have patients where I've taken care of grandma, mom, and the kids, and for different things. And it's really fun. And, there's been occasions where I've had families consider me to be their family doctor because they've all come to see me for various things. But in general, in orthopedics, and we're definitely very goal oriented and we want to figure out what's going on and let's sort out how we're going to fix this. And so I think if you figure out kind of which sort of track appeals to you and really speaks to you, that's your first step. And then if you decide that you're wanting to be a surgeon, then obviously you want to look at all the different avenues in surgery. One thing that I didn't get in my surgical rotations was, at the time, we had very little exposure to ear, nose, and throat, and very little exposure to ophthalmology, and pretty much zero exposure to neurosurgery. And so one thing I would say is in med school, if you think you might be interested in a specialty that you're not going to rotate on, go out of your way to try to learn about it. Because I was a fourth year student and I had a couple friends going into ENT and they were talking about it. And I thought, wow, that kind of sounds interesting. But it was, for me, it was kind of late in the game to do that. And I did end up going and meeting with the ENT chief at the time and talking to him about it. And I just hadn't seen enough ear, nose, and throat to really know if it was for me or not. So if you think you might be interested in something, but you're feeling like you're not going to get it in your rotations, seek it out, because it might end up being something that you really enjoy and you might not have otherwise gotten to experience it. The other thing I would say is know that when you leave med school, you are going to keep learning the rest of your career. And when you start residency, you'll quickly realize that med school is going to prepare you to a point, but you're going to hit the ground running and you're going to learn a ton your intern year. And internship, when I did it, was a general surgery internship. And now I think a lot more orthopedic residencies allow you to do a transitional year as opposed to general surgery, which is definitely much better because it's much more geared towards orthopedics. My friends who did transitional internships, they got to do a radiology rotation, a rheumatology rotation, maybe an ER rotation, and then some ortho rotations, and then some surgical stuff too. But it's the transitional internships are more geared towards an orthopedic residency, whereas I did vascular, general surgery, trauma, cardiac, ear, nose, and throat, urology, a month on ortho, but definitely it was not tailored to an orthopedic residency. So when I started orthopedic residency as a second year, I felt I was really out of my element because I had all this, general surgery and ICU knowledge that wasn't necessarily as relevant to an orthopedic residency. So just know that when you leave med school, you're going to learn so much more, and it'll be, kind of like drinking from a fire hose, and, med school is too. But you're going to learn your whole career. And even now, 25 years into practice, I'm still learning. And so, there'll be times where you'll be faced with a case, you're in the OR and things aren't exactly what you thought they were going to be. And you're going to think, okay, what have I seen that's like this? And then you'll expand from there. And, there's definitely on the job learning, even 25 years into practice. So know that going into residency, and that you'll keep learning throughout all your years of practice.
Thank you. And kind of going on that, someone asked, what were some of the greatest challenges you found yourself having to overcome as a resident? And then maybe in fellowship as well.
So in residency, you definitely will cope with lack of sleep, which you will some in med school too. But in residency, it's definitely even more. And there are times where you'll be dozing off and you're holding a retractor in the operating room because you didn't get a lot of sleep on call the night before. And, the hours are much better now because things are a little more controlled than when I did it back in the dark ages. But it was, there were definitely times where we were just so exhausted. It was hard to think straight, and you will definitely cope with lack of sleep. And you'll learn to deal with people who may not always be, whether it's patients or just, colleagues or attendings, or, people aren't always going to be maybe as nice as you might hope they might be. And you're going to learn to work with a lot of different kind of people, and that can really be a challenge. Sometimes it's cultural differences, and sometimes it's just, people don't see things the same way you might. And so I think there's a lot of challenges in any residency, but in surgical, you're working a lot of long hours, and you're dealing with a lot of different people and a lot of different personalities on different levels. And those are definitely huge challenges. And being a woman in orthopedics, we are a minority. We're a small minority as it happens. And even though there's a lot more women going into orthopedics now than there used to be, it's interesting because we still haven't gained significantly in terms of percentages. When I was a resident, there were 9% female orthopedic surgeons nationwide, and that counted residency and practice. And I think now we might be up to like 11%. So it's still not a huge proportion. So for Lexi and Alex and Alicia, if, just being a woman in a male dominated field, don't be self-conscious about it. And it's, you're a team, and there's a lot more women in ortho than there used to be. And so you are not alone. And that was definitely a challenge during my residency, which I think will be definitely better now than it used to be. But that was certainly, it was a challenge. But you just have to be comfortable hanging out with people from all genders. And it's definitely there's a lot of learning that'll go into it. And you'll develop a lot as a person, and as will everybody during residency. But I would definitely say, from a challenge perspective, coping with the long hours and expectations too. The first time you're on call by yourself and your attending says, well, okay, go deal with this in the ER. And you're thinking, okay, am I going to be able to deal with this? I've never seen this before. And so you might find yourself looking at the textbook before you go down to the ER to see that patient. And there'll definitely be times where you're doing cases as a resident and even as a fellow and when you're in practice where you haven't necessarily seen the case before. So always, be as prepared as you can. Never go in cold. Always take the extra couple of minutes and look something up if you feel like you need to, because it's always better if you have even that little bit of preparation.
Thank you. If you could change anything, and maybe the answer is nothing, but about the field, what would that be?
I think in most surgical residencies, and this isn't unique to ortho, but in most surgical residencies, we're not supposed to show any weakness. And that means like, you're not supposed to be tired and you're not supposed to admit you don't know something, and you're supposed to always be strong and you're always supposed to be on. And that is something that it's a cultural change that would have to definitely evolve, but you're not always going to be at your best. And of course we always will all want to be at our A game, but there's going to be times where maybe you're not. And, maybe you're not feeling well, or you had a rough call night the night before and you were up all night and you still have to work the next day. And so it's just, or it's been, too many days you've been working in a row, perhaps. I think it would be just good for surgery as a whole if our field was a little more accepting of the fact that we can't always be perfect all the time and we can't always all be on our A game all the time.
That makes a lot of sense. Thank you. And just like in general, anyone can feel free to like jump in and ask questions for Dr. Melchior. I think for just like a more general question, how did you decide to move to Boulder specifically?
So I was living in Pasadena, California, and had a great practice there and loved living in California. I did my residency at UCLA, and I grew up in the Midwest and went to school at Northwestern. And then I moved to California and I thought, wow, this place is pretty great. They don't have snow here and it's warm and there's a beach. And not that we didn't have a beach in Chicago, but it's not quite the same thing as the Pacific. And so I really liked living in Southern California, and I left for a year. I did my fellowship in upstate New York at the University of Rochester. And then I moved back to California for my first job. And then I met my husband there 4 years later, and he was from Colorado. And we didn't think we'd be able to move to Colorado because my husband's a chemical engineer. He works for Chevron, and Chevron doesn't have any holdings in Colorado. And so we figured, we'd need to stay somewhere where there was Chevron. And then we found out that there was an opportunity for me here in Colorado. And I said, well, you can't work in Colorado because there's no Chevron. And he said, well, I could take a leave of absence, or I could change jobs. And we looked at the job for me, and it ended up being a good fit, and they offered me the position. And then I thought, okay, now what do I do? Because I wasn't really looking for a job. It sort of fell into my lap. And then my husband told Chevron that he was thinking of leaving, and they said, no, don't leave us. They said, just take a leave of absence for a year. And he said, okay. And then they called him back a week later and said, how'd you like to work for us remotely? So my husband is Colorado's Chevron office. That means our house is Colorado's Chevron office. And so everything just kind of fell into place for us to move out here. And we've been here for 16 years. So
That's awesome. Any plans to, check out any other parts of the country, or you're pretty excited to stay in Colorado?
Well, our girls are 13 and 17, so we want them to be able to finish high school here. But once they're off to college and we retire, then, we're definitely looking at other parts of the country for different phases or different components of retirement. We might spend, we'll probably spend at least a month a year in Hawaii. We might spend some time in California. We have a lot of friends still in California and love it. But we love Colorado too. And we're both, I'm a skier, he's a skier and a boarder. And so we love the mountains too. And it's, there's certain months of the year that are just absolutely spectacular here, like June and September. So I think we'll spend time different places once we retire.
Definitely. And what are your goals for your career moving forward? As you said, you've been in practice for 25 years already, and that's awesome. You said you're always learning on the job. But are there any like specific goals you have, or just, yeah?
So I've been toying with some leadership opportunities within my organization. And I've been doing some things on a national level with hand surgery kind of in general, but also with Northwestern as some other alumni groups that I'm involved with. And then also some aspects through my organization and working, like, for example, I'm part of a national orthopedic committee that specifically looks at the instrumentation we use for trauma surgery. And, we work with different companies and contracts and like, for example, if you broke your wrist, there are a ton of different plates and screws you might use to fix it. And lots of different companies make different hardware for different things. And so a lot of it is what you trained with, but some of it becomes, as your practice evolves, you learn about new techniques and then you change. And so at a national level, we work with different companies and different contracts for various orthopedic equipment options. So that's been really fun, getting to know people nationally and, working at that, at that larger level. And then in my group here in Colorado, I'm the hand surgery representative for our organization. And so, working with our leadership higher up in the organization too. I'm part of a really large multi-specialty medical group. So we have 47 orthopedic surgeons in the group and 1,400 physicians.
Wow, that is definitely huge. Going back to what you were mentioning about hand surgery in particular, do you feel like there's any like major differences between like a hand surgeon that came from a plastics residency versus a hand surgeon that came from an orthopedic residency? Like, do you do different things? Are there different focuses or just differences in experience?
So I think nationally right now, there's about at least 2/3 of hand surgeons are ortho trained. And there's then probably close to 1/3 that are plastics trained. And there's a few that are general surgery trained. You can go to a hand surgery fellowship being general surgery trained, but it's rare because you don't have the background in bone work and bone fixation, and you don't have the background in soft tissue like in plastics. There are not a lot of hand surgeons that are general surgery trained. And so we're probably about 2/3, 1/3 ortho to plastics. And we bring different strengths. When you come out of an orthopedic residency, you are really strong in bone work because you've worked on a lot of large bones, you've worked on a lot of small bones, you've done a lot of hip fracture, you've done a lot of femurs, you've done a lot of tibias, proximal humerus. Part of your residency is spine, and some of it is total joints. And so you're seeing large and small. So you're good with pins, plates, screws, rods, you name it. But you're not going to be quite as good at soft tissue as the plastics people. They have much more training in flaps and skin grafts, and whether it's a rotation flap, a free flap, a pedicle flap. So the plastics folks are much better with soft tissue in general, but they're not as strong with bone. So when you do a hand fellowship, the plastics people need more training in osseous work, whereas the orthopedics people need more training in the soft tissue. So we bring different strengths to a hand fellowship. And I've got really good friends around the country who are plastics trained and really good friends who are ortho trained, and they're fabulous hand surgeons. But the hand fellowship, I think, is what really kind of brings it all together.
Thank you. And then I think just more in general, what advice would you have for any of us here or any of our classmates that are interested in orthopedic surgery and like want to get further involved in the field, want to develop like research interest? So I guess like people who are already like leaning that direction, what would you recommend?
And it's great that you're thinking about it as M1 and M2s. It's really good to start thinking about it early. It's hard if you wait until you're an M4, because then you might not have all the background you might want to have going into orthopedics. Ortho's competitive, it always has been. And so I don't think that's changed a whole lot since I was applying. So have as many cards in your deck as you can. Be involved with research. Even if it isn't orthopedic research, any research looks good on a residency application. Any research, whether it's lab work or population based registry work, whatever it is, research always looks good. It will never hurt you and it'll always help you. Community service is always good. Volunteer work is great. Orthopedic residencies, you don't have to be an athlete to go into ortho. Sometimes it's helpful, but it isn't necessary at all. I wasn't an athlete. I mean, I have athletic interest, but I didn't play a high school or college sport. And so sometimes people feel like, oh, well, I wasn't athletic. So, maybe that isn't for me. So don't worry about that part of it, but be as well-rounded and broad in your interests as you can. People are looking for incoming residents who have varied interests, not just book smart. They're going to be interested in anything about you that's different, that makes you unique, that that might help make you a better orthopedic surgeon and a better fit for their program. So I would say, have as much on your resume, on your CV as you can. And, whether that's, obviously grades help, that's important too, but it's more than that. So look at research, look at community service, look at volunteer work, anything that helps make you stand out and have a broad spectrum of interests.
Thank you. That's very helpful. Were there any other subspecialties within ortho that you kind of considered for a bit? I know that you really liked hand because of like the overlap with plastics a bit, and you had that early interest, but anything else that stood out to you?
Well, I really did like sports. Sports can be a lot of fun. When I was at UCLA, we got to work with the UCLA football and basketball teams, soccer teams, and it was really fun working with the athletes. They were great. Just getting to meet them and work with them was really a privilege. And so there's a lot of fun things in sports. Another orthopedic subspecialty that I really liked that I never even thought about before was orthopedic oncology. And that we had a really strong program for that at UCLA. And there's not a lot of orthopedic oncology programs in the country because it's a very specialized field. There aren't a lot of primary orthopedic tumors, primary musculoskeletal tumors. There's sarcomas and there's a variety of other things, but it's a really unique field and it's fascinating. And our professor who ran the program at UCLA was an amazing teacher, and I learned so much from him. And it was just some of the surgeries they did were just massive. And our orthopedic oncologist would partner with the surgical oncologist, and they would do the case together. And then there'd usually be, we'd have a resident and a fellow there also, and a med student. And so, I mean, we would do, an entire like distal femoral replacement, which is different than a knee replacement where you're just resurfacing the femur and the tibia. With a distal femoral replacement, you're literally removing the entire distal femur. And that can be, 10, 20 centimeters of femur you're taking out. And then you're putting in a prosthesis that is a distal femur. And then of course there's the linkage to the tibial part of it too. And so those surgeries were just incredible to see. You probably wouldn't find those on YouTube. They're amazing. And some of the work that team did, you never saw anything like it. So I was really interested in that, surprisingly to me. But orthopedic oncology, it's hard because most of orthopedics, your patients are healthy and they're active, or they were active and they want to be active again. And, those are your ACL reconstructions and your hip and knee replacements and your shoulder, your labor repairs. And somebody has, in my world, you have arthritis at the base of your thumb, and it's gotten so painful that people can't do their artwork anymore, or they can't paint anymore, or, they can't do the things they want to do. They can't play their musical instrument. And so there's a lot of restorative to orthopedics. And most of the time patients want to get better. They want to get back to whatever they were doing before that their orthopedic problem isn't allowing them to do anymore. And so that's one of the things that really appealed to me about orthopedics is the patients, they wanted to get better. They wanted to have the surgery, and they wanted to do it so that they could do the things that they love doing. Whereas in the other surgical specialties, it wasn't quite like that. In general surgery, unfortunately, there's, a fair bit of cancer or chronic, gastrointestinal problems or diverticulosis or whatever. And so unfortunately, some of those people, they really maybe didn't want to be there to have their surgery. Whereas in orthopedics, a lot of the patients really, really wanted to have done whatever we were doing. And, so my interest in hand also stemmed from the fact that I had two fantastic mentors at UCLA, the two hand surgeons who were the attendings there at the time. One was a plastic surgeon, and he's probably the best soft tissue surgeon I've ever met, and still is. And then the other one was an orthopedic hand surgeon, and he was an incredible teacher. And so I was very, very fortunate to have two incredible mentors in hand surgery. And that's the other way that I came to hand surgery, was getting to work with those two people.
Thank you. And I guess what advice do you have for us then? I know we're much earlier on in training, but finding a mentor here that we can develop that relationship with and ask for advice about our future career goals.
Mentors come in many shapes and sizes, and they're everywhere. You just sometimes have to look a little bit. It might be a resident in orthopedics, and it's someone that, say you do a third year rotation, or whenever you rotate on orthopedics nowadays, there might be a resident that you click with, and don't be shy about asking them for mentorship. Hey, I think I might be interested in orthopedics. I know I'm going off service in another week or two, but, could we keep in touch? Could I come shadow you, in the operating room, or, can we, hang out, or can I, go with you if you're, going to be doing a shift wherever, or it might be a resident, it might be an attending. It doesn't have to be an attending. Residents are great mentors. There was a senior resident when I was med student, and she was tiny but mighty. And she was probably barely 5 feet tall and like 100 pounds dripping wet. And she was tough as nails. And I learned a lot from her. And you never know where mentors are going to come from. It might be someone who isn't even at Northwestern right now, someone like me. And, Northwestern has thousands of alumni physicians out there, and people are more than willing to mentor students and help out and advise and connect you with people where you might be like doing away rotations, for example. You know, that when I was going into ortho, that was key. You had to do at least one away rotation as a fourth year. And I'm not sure exactly what year that would fall in for you guys right now, because I know when I was in med school, the first 2 years were mostly clinical. They were mostly book learning. It was mostly lectures. And then the third and the fourth year were more clinical. And I know now it's a lot more blended, which is, I think, good. So you have lots of alumni options as well. And that's something that, you know, Allison and Jillian can help you get connected with. There's lots of us out there that love to get to know students and help out students. And I mentor, I've mentored a variety of folks over the years, and I have an active mentorship that's been ongoing for years with a young woman who's, I met her when she was a fourth year resident through another Northwestern alumni friend, and who knew this young woman's husband. And so she and I have been, you know, we've been friends for years now, and she's now in her third year of practice. So I've known her for probably 6 or 7 years, and she still calls me if she, you know, has a question about a difficult case, or if she's, you know, wondering what the right thing to do is, and, or if she had something not go so well, and, you know, she'll call me and, you know, we'll talk it through. And so finding a mentor is really helpful. It's not hard. You just have to reach out.
Thank you. That's very helpful. As somebody who is, you mentioned you're interested in like leadership in orthopedics, are there any degrees or like things that people can get involved in that you think would make someone more qualified or just help in pursuing those sorts of positions in the future?
Well, when I was in school, we didn't get a lot of training in business of medicine. And that, I think you all probably get a little bit more exposure to. I don't know how much of it is part of your curriculum at this point, but a lot of physicians who are interested in management, leadership, or administrative roles do end up going back and getting an MBA later. And there are any number of executive MBA programs out there that are tailored specifically for physicians, but it doesn't necessarily have to be an MBA. There's sometimes people are interested in public health and, you know, and want to do that avenue. And so there's MPH programs out there. And that's not to say you need an advanced degree, because there are lots of physicians in leadership roles who do not have masters in business or public health or anything else. But, you know, if that's something that appeals to you, then that might be an avenue that you look at later on. I'm pretty sure Northwestern has an MD MBA program, as well as an MD JD and MD PhDs. But that may be something that has already been set by the time you start medical school. I'm not sure of the exact logistics with Northwestern, but it's not, and again, that's not to say you have to have a master's to be in leadership, because you don't.
Great, thank you. And I guess for people who are interested in getting involved in public health, do you feel like there are opportunities to do so within orthopedic surgery, or is it a little bit more challenging, I guess, due to like the surgical nature and how busy your schedule is already?
I have a lot of friends who've done volunteer work with a variety of organizations, Doctors Without Borders, Orthopedics Overseas, Hand Surgery Overseas. There are a lot, and many others. Those are just kind of the three big ones that a lot of people have heard of, but there are lots of opportunities to do volunteer work and community service and outreach work. And sometimes it means you go to another country for a week and you see patients and you operate and you just go for a week, and then you come back. And I have a lot of friends who've done that. And then I have a friend who does overseas work, and he takes a team every year and goes to the Philippines. And, you know, he takes nurses and anesthesiologists and scrub techs and surgeons all in this group that he coordinates. And they go to the Philippines every year for, it's like a week or 10 days. And unfortunately, COVID kind of snuffed that for a while. and it's just kind of starting now to get back in the swing of things. But there are lots of opportunities for avenues in that regard that are sometimes and you can choose it. You can choose the opportunity. I mean, sometimes it's more public health, like, educational. Sometimes it's more just going to an underserved area and, doing orthopedic surgery for a week straight. And, you see patients in the morning, or you operate in the morning, and then you see patients in the afternoon. And those are very, very rewarding experiences. It sometimes is hard, though, to find the time to do it. And because you are super, super busy. And it's a really worthwhile thing to do if you can fit it into your schedule. It's very rewarding, and it's a great way to be able to give back.
That's awesome. Thank you. And I know you mentioned that your schedule has changed a lot, like over the years, whether it was working like full time at 100% or going at 90%, and now at 75. Can you kind of talk about what that looked like for you, whether that's like your current week schedule, and then like maybe also when you were starting in Colorado and working at like 100% capacity, what did your weeks look like?
So in my old practice in California, the way it worked was everybody worked 4.5 days a week was a full schedule. And so typically that'd be 1 day in the operating room, that'd be 1 day in the office, that'd be 1 day on call. Then there'd be a day in what we call enhanced surgery. We call it minor surgery. So it's procedures that we do under local anesthetic. So I do most of my carpal tunnel releases, trigger finger releases, what I like to call lumps and bumps. Anything I can do under a local, I can do in minor surgery, which is great for the patient because they don't have to be NPO and they can drive themselves. And it's a really nice way to it's a minimally, not quite hassle-free, but it's a pretty straightforward way of having surgery done. So kind of a typical week is, 1 or 2 days in the office, 1 or 2 days in surgery, a call day, and sort of a mix in that regard. And when I came out here to Colorado, our schedule was a little bit different. Here, a full work week was 4 days a week. But we had an extended day. So we start seeing patients earlier in the morning and we finish later than some of the other surgical subspecialties. Working 4 days a week as a full-time schedule meant that you always had 1 day a week off, which is beautiful. And again, it was, usually 1 day at the hospital or the surgery center, 1 day in the office, 1 day in minors-ish. Now it's kind of evolved to kind of every other week I have a minor surgery full day. And that's, those days we're doing 10 or 12 surgeries. And then if it's a regular day in an operating room day in the surgery center where I have an anesthesiologist with me, I'm usually doing 4 to 6 surgeries in a day. And those are bigger surgeries where I need an anesthesiologist. So, that might be, fixing a wrist fracture or, metacarpal fractures or repairing cut flexor tendons or cut nerves, or it might be, Monday I did, an elbow fracture dislocation where I had to replace the radial head because it was in too many pieces to fix. And then I had to plate the olecranon, which was in a lot of pieces as well. And then I had to do a ligament repair because he had also dislocated when he broke his elbow. So that was a complex case. We were in the operating room about 4 hours for that one. And then I fixed a couple of broken wrists after that. And then I had a couple of carpal tunnel releases after that. So there's a lot of variety to a surgery day. And there's days with the anesthesiologist, which are your bigger cases. And then there are days where, at least for hand, where we do things under local. If you go into sports or spine or total joints or orthopedic oncology, then you're going to be doing pretty much all of your cases with an anesthesiologist. So you'll be in a surgery center or occasionally in a hospital. The joint replacement surgeons, usually they're in the hospital for their surgeries most of the time because the patients spend the night, but even that's changing. Our goal for the organization for next year is to do 80% of our joint replacements outpatient. So that means total hip and total knee, they come in, have their surgery, and they go home that night, which is very unusual because the tradition has always been, they always spend at least a night or even 2 or 3 in the hospital. But in this era of, wanting everything to be outpatient surgery and minimizing people being in the hospital. And of course, from a COVID perspective, there's not a lot of beds available for elective procedures because patients are in the hospital sick with COVID. And so there are some hospital systems right now that have curtailed elective surgeries. When we were in the very beginning of COVID, it was all elective surgeries were shut down for 2.5 months. And so there were no joint replacements being done. There were no ACLs being done, no rotator cuffs. And, in my world, we were only doing trauma. We were only doing trauma stuff. And so then once we got ramped back up, of course, there was a huge backlog of people who needed surgery because things had been put off. And right now there's certain places around the country where they've curtailed elective surgeries again because they just don't have the beds and they don't have the staff because of the people who are sick with COVID. So, but in general, a week is, you'll have probably 1 or 2 office days, you'll have 1 or 2 surgical days. And that's kind of how a week will run in general, in any surgical specialty.
Thank you. And I guess, is there any case other than the one that you mentioned that stands out to you in like the last few months that's been like a really cool one or very memorable one that you can share with us?
I have a personal fascination with lumps and bumps. I happen to love removing masses because I think they're fascinating, because they might be a straightforward ganglion cyst, for example, or a lipoma, which is a benign fatty tumor, but sometimes they're not what you think they're going to be. And, I took care of a lady a couple of weeks ago who had a mass in her palm, which we thought was probably a ganglion cyst, but it was in a little bit of an unusual location. It was in between her fingers rather than kind of right over the tendon. And we had tried draining it in the office. I hadn't gotten any fluid out. And sometimes fluid in a cyst is just too thick to pull out through a needle. And so she's decided she wanted it out. She had it for years. And so we went to surgery and, I'm exploring the mass, and it was turned out to be a benign nerve tumor. And it's called a schwannoma or a neurolymoma. And it was coming from one of the small nerves to her ring finger. And it just wasn't what I had expected at all. And which made it really interesting. And so that's part of the fun of surgery is, things aren't always going to be cookie cutter, and they're not going to be always exactly what you meant and what you thought it was going to be. And so a case like that was really interesting. And that was a case I was doing under local. So she was awake. And so I was able to tell her, hey, this is something different than what we thought. And then she said, well, can I see it when you take it out? And I said, sure. So she actually got to see her mass once we took it out, which she thought was super cool. So that was another recent case that was just really interesting because it was a little surprising.
That's really cool. Thank you. And I know that, I don't know if you have any time limitations. I know we're at the hour, but if, you want to stay on, if anyone has any questions, I don't know if Allison and Jillian, like you have any pointers now.
No, I think this was great. I think, thanks for your time. If nobody else has any questions.
Feel free to jump in if anybody has any questions. No?
Yeah, no, it's been great. And thank you so much, Dr. Melchior. And if any of the students have any extra questions, if something comes up, yeah, you have my email, so I can, email me, please. And then I'll reach out to Dr. Melchior and let her know and connect you too. But thanks again, Dr. Melchior. This was great and lots of good information. So I appreciate it.
Really fun to meet everybody, even if it was only virtually.
Yes.
Someday we'll get back to in-person meeting.
Someday, yes.
So thanks everybody for taking the time to hang out tonight. And please feel free to reach out if you do have any other questions or, if I can be of any help to you.
Yeah, have a good night, guys. Thank you.
Thank you so much.
Thank you.
Thanks.
Take care.
Take care. Happy holidays.
Happy holidays.
It's great to meet you. Thank you so much.
Yeah, you did great. I thought it went really well. So it was great
There
chat.
were some wonderful questions, and I feel like Dr. Melcher, you just gave such like wonderful, like thorough answers to everything. It was so interesting. So I appreciate it a lot. And I'm glad we got to meet virtually.
Well, hopefully maybe sometime we can meet next time I'm in Chicago. I'm usually there. I'm there twice a year. Because I'm there for Northwestern's Council of 100, which is a women's alumni mentoring and career counseling group.
That's awesome.
And so I'm usually there twice a year. And of course, with COVID, we've been meeting virtually, but we're hoping to get back to in-person meetings in 2022. So, and usually in the fall, we're on the Chicago campus. So in the spring, we're in Evanston campus. So I usually am in Chicago at least once a year for alumni things. So
Awesome.
Yeah.
Yes, would definitely love to meet in person. We could make the trip up to Evanston. I'm sure a ton of people would love to hear from you again, but I appreciate it.
well, you're very welcome. It's a pleasure, and best of luck with everything. And let me know if I can be of any help to you.
Thank you. I really appreciate it. I will definitely reach out.
Please do. All right. Take care.
Have a good night.
Thanks, you
care.
too. Bye-bye.
Bye. Take care. Have a good one.